Patients with small anatomy present unique challenges in shoulder surgery. I feel it's really important to choose an implant system that adapts to your patients as opposed to trying to choose patients that will adapt to your chosen system. This is a patient who presented to me who's a 72-year-old gentleman with persistent shoulder pain that had been ongoing for several years. He was unable to really lift his shoulder effectively, and he had decreasing function. He enjoyed traveling and playing golf, but wasn't able to do those things as a result of his shoulder pain. He had failed a long period of non-surgical management, including injections and physical therapy. On examination, he had true pseudoparalysis with decreased elevation of his shoulder, loss of external rotation, and was only able to internally rotate to his back pocket. He actually had an external rotation lag, signaling the fact that he had significant loss of the external rotators of his shoulder. His initial radiographs, as you can see here, demonstrate elevation of the humeral head with the beginnings of rotator cuff arthropathy on his x-rays. On his axillary x-ray, you can see that the joint space is relatively well preserved, but he has some anterior subluxation of his humeral head demonstrating insufficiency of the subscapularis muscle. Here are his MRI scans, which demonstrate atrophy of the muscle. You can see the retraction of the supraspinatus and infraspinatus back to the level of the humeral head, and there's a lot of atrophy of those muscles, so the likelihood of repair in this setting is extremely low. So when we think about the options for this patient, we consider non-surgical management, which he's tried for quite some time. We can consider the surgical options, which would include a reverse shoulder arthroplasty, and in this setting, we felt in our discussion with the patient that that was the most predictable option for getting him the best result. So I chose to use the Univers Revers system in this patient. I believe the advantages here are that you have a press-fit stem. You can choose a 135 or a 155 implant. For me, I choose a 135 for this patient because we were able to optimize lateralization as well as avoid some of the complications we're aware of in the world's literature, such as scapular notching. I personally prefer an inlay design, as this avoids some of the recently reported complications of acromial stress fractures. So the modular glenoid system allows us to adapt our implants to our patients. The optimal fixation can be chosen by the surgeon, whether that's a post or a screw. We have different lengths of the central fixation. In this patient, we chose a 20mm screw. This can be a 15 monoblock screw, all the way up to a 35 screw if you need to place a bone graft for certain patients. On the base plate side, we can use an offset base plate for metallic lateralization, and this can be a neutral or up to a +4 lateralized base plate. And then we have multiple sizes and offsets on the glenosphere side. We have eccentric glenospheres that we can use for our patients, as well as a 33 glenospheres for very small patient anatomy, up to a 42 glenosphere. Here you can see our patient's VIP plan. I personally obtain a CT scan in all of my shoulder arthroplasty patients. This really allows me to get the central pin in a perfect position. And in this case, it's very important, as you can see, because we can correct our patient's inclination and we can correct version if needed. In this case, this patient's vault is very small. And so for me, I'm trying to use the right size screw, and in this patient, this is a small screw, and we need a smaller base plate. This is a 24mm base plate that you can see displayed, and this is what we ended up using, which was optimal for him. So here's some intraoperative video demonstrating our placement of the base plate. You can see he does in fact have a small glenoid, but because the central fixation is quite small and the base plate is quite small, it fits very nicely for our patient. Part of this is using our intraoperative VIP guide to get that in the perfect spot, and then we're able to really evaluate the perfect glenosphere intraoperatively by using our intraoperative sizing guide. There's multiple glenosphere sizes, as we talked about. In this patient, a 36+4 plus a +2 lateralized base plate allowed us for +6 lateralization for optimizing his range of motion and, again, avoiding scapular notching. The 24 base plate with the 20 screw fit very nicely. Once we got our final glenosphere impacted into position, we took the shoulder through a range of motion, and our range of motion on the table was excellent. Post-operatively, when I saw the patient back, we had reversal of his pseudoparalysis. We were able to see him at 6 weeks with excellent range of motion and no pain. What I really appreciate about this system is its versatility. It's truly allowed me to more effectively address a wider array of patient anatomy, including my small patients. Thank you for your attention.